Greetings. So, let's talk about sodium and water. Okay. Again, I've divided this video into two parts. First is to understand some key principles. Okay. And then the second part is to actually apply the key principles. Okay. So, let's get started. So, whenever we are assessing sodium and fluids, there's some key principles. Let's start with those. The first variable to consider and assess is extracellular fluid status. So again, in your patient, um, when you're looking at extracellular fluid status, it's important to know whether the patient is hypervolemic, hypovolemic, or euvolemic. And I've covered this under fluid assessment in the renal section. Okay. The second thing that would be given to you, not the second variable to consider, but the second thing that you would have are plasma sodium levels. Okay, so in other words, you're going to draw blood, send it to the lab. Lab's going to say, hey, this is the sodium concentration. They may say it's 140 milliequivalents over 1 deciliter. Okay, so again, it's the amount of sodium that's there in a certain volume of your blood. Now, remember, plasma sodium levels or concentration is the same as interstitial sodium concentration is the same as extracellular compartment sodium concentration, right? Yes. If you're not sure about this, you got to review my previous videos on fluid anatomy and physiology under renal. Okay. We've covered these concepts extensively there. Okay. So we get this picture where extracellular sodium concentration is the same as plasma sodium, is the same as interstitial sodium, right? Now, is that does that make sense? Yep, perfect. Now, that tells me that plasma sodium, which is the same as extracellular sodium concentration, if we multiply that by the fluid status, or how much is the total fluid in the extracellular space, remember that variable one, right? That should give us an idea of how much is the extracellular sodium. Okay. All right. So, and that would be total extracellular sodium. Okay, so this is the amount of sodium that is there in the extracellular space, which is the concentration of the sodium in the extracellular space times the total amount of fluid. Makes sense, right? So remember, concentration is what? Mass over volume. So what we're saying is, hey, how much is the total mass of sodium? Well, it's concentration of sodium, which we calculated with the lab, times volume, which we calculated with our variable 1. So now we have extracellular sodium, right? Okay, that's our total sodium in the extracellular space. Okay, now remember we have the extracellular space and the intracellular space. Where's the sodium more? It's way, way more in the extracellular space, right? So we don't worry about this, right? Now, even within the extracellular space, right, the concentration is the same for the sodium in the extracellular space, which is the interstitium and the intravascular. However, which has got more volume? Interstitial, right? But either way, we've got the extracellular sodium, and because it's super duper gooper high here, we can approximate and say, you know what? If the extracellular sodium If I can get my hands on how much is my extracellular sodium, that's about the same as total body sodium, because guess what? Inside the cell, there's not too much sodium. Okay, so it's very simple. Now I have two variables, right? Let's go through this. We have the extracellular fluid, so we assess that, and we were able to assess our total body sodium. How did we do that? We got the plasma sodium, we multiplied that by our fluid status, which is EC fluid status, extracellular fluid status. We got the extracellular total sodium, which we said because that's the most of our sodium, that approximates to total body sodium. Okay, and now we have this chart in front of us, which is the problem for sodium and fluid is divided into two parts. Your extracellular fluid, you have too much, too little, just right. Remember Goldilocks? That's it. Too hot, too cold, just right. Too much, too little, just right. Okay. Same with total body sodium. You have too much, too little, and just right. Okay. What do you do if you have too much fluid? You get rid of it. Diurese. Get rid of it. Okay. And then if you have too much, you're going to restrict it. Right? Makes sense. What if you have too little of extracellular fluid? What are you going to do? I'm going to replace it, man. You know? Yeah, I got to give them more. If it's just right, you're good. Okay? Total body sodium. You can have too much. What are you going to do if too much? You got to restrict it and you got to excrete it. Okay? Get rid of it. What if you got too little of total body sodium? I got to give me sodium, right? What if it's just right? You're all good if it's just right. Okay? Now, this is the immediate management of sodium and fluids. And what we do is we diagnose and treat underlying conditions that are causing these two to be abnormal, because your body is going to make sure you keep it very tightly regulated. Okay. Now the question is, how does the body do that? Let's take a look at that. So there's two big areas to consider when we're thinking about control of sodium in water. Of course, there's intake and there's excretion. The two big ones to think about are aldosterone and ADH. Okay, aldosterone. What does it do? I'm going to absorb sodium and water and give out potassium in my urine. Remember that? You're not sure. Um, Watch out for my videos in the endocrine system, where I cover aldosterone and I cover ADH. Okay. Now, how is it activated? Well, what happens is when the EC fluid, right, extracellular fluid goes high or low, RAS system is activated. Okay. And so remember, we covered this. You have the glomerulus, loop of Henle, okay, and then you have that juxta. You have the apparatus. And what the apparatus does is, if you've got very high amount of extracellular fluid, there's a very high amount of fluid that goes through the tubules here. Okay, that's sensed. That's sensed, right? Okay, and when that's the case, aldosterone turns off. Because aldosterone turns off and the sodium and water are not reabsorbed, and we pee out the sodium and water. So what's going to happen to the urine sodium? It's going to go high. So if the extracellular fluid is high, there's no aldosterone, okay, and high urine sodium. Okay, we've covered this already, but it's just a refresher. If I've got too little extracellular fluid, my aldosterone's going to kick in, and it's going to reabsorb sodium and water, which means the urine sodium is going to go down. Okay, we're still on basics. There's another hormone, which is ADH. And what ADH does is, when it is activated, it absorbs only water. So you don't absorb sodium, you just absorb free water. Okay? So how does it get activated? It's got to do with plasma osmolarity. Okay. When plasma osmolarity is high, ADH is released and it absorbs water. And that the goal is for the concentration of the blood or the plasma osmolarity to go down. That's what that does. And it does it by reabsorbing water, and so the urine is more concentrated and urine osmolarity goes high. Okay, so again, if let's do some critical thinking here. So these are some basic concepts. Now let's say you have a you're euvolemic with your extracellular fluid, okay, and your plasma osmolarity is down. What does that mean? That means your plasma is not concentrated and your fluid status is euvolemic. Okay? Okay? So have a think about this. Okay? What do we need to do? Right? Okay. So when the plasma is not concentrated, it's dilute. So what is your ADH going to do? Antidiuretic hormone. Your body's going to say, look, man, I got to get rid of this extra fluid. So the ADH, antidiuretic hormone, is not going to kick in and not going to take up water. And your urine is going to be dilute to get rid of just free fluid. Right? So your urine osmolarity will be down because it's dilute urine. Right? Makes sense. But you see how this concept is applied in the body. Let's do it the other way around. Let's say I have plasma concentration that's very high and ECF that is euvolemic. Okay, what does that mean? Well, this is very concentrated blood. I need free water. ADH kicks in, reabsorbs H2O, free water, and then urine becomes more concentrated and urine osmolarity goes up. Right? Check and check. Makes perfect sense. Okay? So that's the two mechanisms. Now remember, we're going to do something here. So remember we had ECF fluid and total body sodium, right? Too much, too little, just right. Too much, too little, just right. Right? So essentially when we are looking at these problems, we have 9 states in total. We have total body sodium. It could be too high, normal, too low. Extracellular fluid status, which could be too high, just right, and too low. Okay, and that's what we are trying to do, is to figure out where the patient is and then manage it appropriately. And while we're managing, we've got to figure out if they're not here, which is normal total body sodium and normal total body fluid status. Well, why are they in these other areas? And what diseases are causing it? What pathologies, abnormalities? We got to manage those. Okay. Now, next thing, is this truly a problem of sodium and fluid? That's just the part that's interesting. Sometimes you will see a derangement in sodium and fluid, but that will have nothing to do with sodium and fluid. It's how we measure them, and there are factors that interfere, and we need to have an understanding about it. The reason is that way, that's our first step, and we're teasing these problems out. Because if it's not a problem of sodium and water, we don't need to figure out what state they're in, because it's a different problem. Okay, and you'll see what we are talking about in just a second. So let's do it step by step. So what does sodium control? Okay, the big thing it controls is extracellular excitation. That's a big term, but what does that mean? That means essentially what it does is by increasing and decreasing the tonicity of the extracellular fluid or extracellular space, it pulls out or gives fluid to the cell, and that's inside the cell. So the cell either shrinks or it swells. This is my cell. It either shrinks or it becomes bigger because of sodium and what it's doing to the extracellular tonicity or extracellular osmolarity. We've covered that concept and the difference already. So how does it do that? So what it does is, so your plasma osmolarity, which is the same as in interstitium osmolarity, which is the same as extracellular osmolarity. We've covered this as well, right? Which is actually the same as intracellular osmolarity, right? The osmolarity is the same between all compartments. Okay. What's different is what solutes are causing this osmolarity in between intercellular space and extracellular space, right? So again, plasma osmolarity is 2 times sodium plus glucose divided by 18 plus Bun divided by 2.8. So what's the biggest contributor of plasma osmolarity? Let's say I have sodium at 140, glucose at 120, and Bun at 15, right? So when you do the calculations, this would be 280. Right off the bat, sodium gives you 280. This gives you maybe 5. This gives you maybe 5, right? So compare this to the two numbers that are coming up here, 290. Which is the biggest contributor? Sodium. So in my extracellular space, in my extracellular space, in my extracellular space, sodium is the biggest contributor to my osmolarity, or it is the biggest reason for these fluids moving back and forth. Okay, you with me so far? Hang in with me, almost there. Okay. All right, so if plasma sodium is down, plasma osmolarity is down. If plasma sodium is up, plasma osmolarity is up. Okay, so if I have plasma sodium that's down, I have hyponatremia, right? That means if it is a problem of sodium and water, I should have what? Hypotonicity. If I have hypernatremia, too much sodium in my extracellular space, I should have hypertonicity. Makes sense, right? Because sodium is the biggest contributor to the plasma osmolarity, or actually, technically, plasma tonicity. Okay, so if hyponatremia is not hypotonic and it's hypertonic or isotonic, that's not a sodium and water problem. That's something else. Similarly, if hypernatremia is not hypertonic and it's hypotonic or isotonic, that's not a sodium and water problem. That's another problem. So we actually divide. So let's focus in on hyponatremia. So we divide hyponatremia into whether it's true hyponatremia or false hyponatremia. True hyponatremia is hypotonic hyponatremia. False hyponatremia is also called pseudohyponatremia, and it could be what? Isotonic hyponatremia or hypertonic hyponatremia. Okay, you with me so far? Perfect. So that's the concept, is I can look at my blood levels, I can look at plasma sodium, I can assess extracellular fluid in my patient, and these two would give me total body sodium. Okay, I can also see my plasma sodium, and I can see what my osmolarity is. I can measure it, and I can calculate it. And I can see if the patient is hypertonic, hypotonic, and isotonic, well, either one of those. And if my plasma sodium is high, I need to be hypertonic if it's an issue of sodium and water. If not, if I'm isotonic or hypotonic, that's a different issue. You with me on this? If my plasma sodium is low, if it's a sodium water problem, I need to be hypotonic. Okay, that's true issue. Okay, again, if I am hypertonic or isotonic, when my sodium is low, when my plasma sodium is low, that's false or pseudo hyponatremia. Okay, again, we're just going through some basic concepts. We're not applying any of this at this time. Okay, we're going to apply it coming up soon. Okay, next, let's take a look at symptoms. So remember, sodium, and do you see CNS? So there's an N here and an N here. That's how I remember it. The biggest thing to remember with sodium and symptoms is CNS symptoms. Okay? Everything is nausea, vomiting, diarrhea, or headache. Okay? So in exam and oftentimes in real life, this is what separates. Whenever you're given a problem of sodium and you have central nervous system changes that are given to you, your levels are now correlating with symptoms. So what are the symptoms? So this is the normal, which is 135 to 145. Okay? As you start to go higher, 150, 155, 160, start to get irritable, lethargic, weakness, twitching to seizures and coma. As you start going lower, it's nausea, lethargy, headache, obtunded, seizure, coma, respiratory arrest. So here's the fun part. It's CNS, central nervous system symptoms, and they're bad on both sides. Okay? And they're not very specific. It's just bad on both sides. So we want them to be normal. Okay? There's another aspect to this, which is if the levels of sodium change chronically or over a longer period of time. So let's say this is my cell and the levels outside start to go up slowly for the sodium. And remember, because it's a sodium and fluid problem, the tonicity will increase as well. As it starts to do that, if this process happens slowly, the cell is going to, the water is going to come out of the cell, remember? Okay, and the cell's going to shrink. But if it shrinks slowly, it's not going to get damaged as much and it's going to adapt. If this thing happens very quickly, this is where the cell doesn't adapt and gets damaged, and you actually start to see symptoms. So you see the symptoms, but also remember that the levels may not always give you symptoms because it has to do with their clinical course and how quickly has those levels changed. Okay? The treatment is based on symptoms, not absolute numbers. Okay? That's principle 1 for treatment. Principle 2, change, manage sodium and fluids slowly, really slowly. Why is that? Remember, acute changes are where cells get injured. So if they're coming in with a big derangement and you're very aggressive and you give them aggressive therapy which changes their tonicity acutely, that may be as injurious to them, probably more than the original abnormality. So this is a time where we go very, very slowly and very judiciously and very carefully. Okay? Best way to treat sodium in water, give it by mouth. Don't give it IV unless you don't have a choice. If IV is required, see if you can use isotonic. And we'll get that in just a second. We'll talk about it in the next video when we talk about treatments. Okay, because remember, isotonic will not cause sudden shifts. So if they're hypertonic, right, then you have isotonic, then you have hypotonic. So if they're hypertonic, right, you may want to give them hypotonic fluids. Okay, but what is that going to do? Change the osmolarity very quickly, right? Versus if you give them isotonic, there's less difference between hypertonic and isotonic. So there's going to be a smaller shift. Remember? Slow, 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 slow. There is one exception. It's symptomatic severe hyponatremia, where we actually on purpose use 3% sodium chloride, which is what? Hypertonic. This is done in ICU setting. But remember, it's symptomatic severe hyponatremia. Okay? And we'll talk about it too. So, if you have hypernatremia, if it's mild, give something by mouth. If it's moderate, sure, IV, prefer isotonic. If it's severe, IV, again, we try to stay as close to patient's tonicity as we can. Okay? If it's hypo, if it's mild, we give by mouth therapy. If it's hyponatremia, it's moderate, we may consider IV. If it's hypo and it's severe, if it's severe hyponatremia with symptoms, okay? And remember, that would be acute hyponatremia. Because remember, generally acute hyponatremia is when the cells don't have time to adjust and they cause more symptoms. But anytime where it's severe hyponatremia with symptoms, and we've covered those symptoms, they have seizures, right? They are obtunded. Okay? That's the time to consider the 3% sodium chloride. It's done very slowly and in an ICU setting. Okay, so let's do a quick recap of what we covered here. We talked about some key principles. First principle, I'm going to assess the fluid status on my patient. Second, I'm going to see what the plasma levels are. Third, I'd use those two variables to figure out what the total body sodium is. And essentially, I have two problems with sodium and fluid. My extracellular fluid, which could be too much, too little, just right, or my total body sodium, which could be too much, too little, just right. I got to manage those two. The general principle is too much, get rid of it, too little, replace it. And then diagnose and treat underlying cause. We talked about aldosterone and how it kicks in when the fluid status goes down, right? Absorbs sodium and water, decreases urine sodium, and ADH, which kicks in when the blood becomes very concentrated. Okay, that's when ADH kicks in, absorbs water, free water, which decreases the plasma osmolarity, but increases the urine osmolarity because now urine is concentrated. Okay, we talked about false or pseudo hyper and hyponatremia, and because sodium is the biggest contributor of extracellular tonicity, if you have high sodium, I am expecting high tonicity or high osmolarity in the patient's blood if it is a problem of sodium and water. If not, it's another problem. Same thing with low sodium. I'm expecting low tonicity if it's an issue of sodium and water. If this is not the case, then it's actually false hyper and false hyponatremia. Okay, so that's the next concept that we talked about. After that, we did a quick overview of symptoms. We talked about how the symptoms usually develop based on how acute the changes are. And the symptoms are basically CNS symptoms, or central nervous system symptoms. Okay? We talked about some basic principles. I'm going to give treatment based on what the symptoms are. So if the symptoms are mild, you know what? I'm going to give by mouth. If symptoms are moderate, I'm going to give IV. If the symptoms are severe, now I'm going to give IV, and I'm going to consider big guns. I'm going to give my therapy by mouth versus IV. Okay? I'm going to do it slowly, and I'm going to do it to where the shifts in the osmolarity are least, and they're slow. There's one exception, which is 3% sodium chloride that we use in ICU, where we are actually making substantial changes to the tonicity. But again, we do it very slowly in an ICU setting.